And thank you also for your questions. I mean, just really interesting questions, and I've enjoyed doing a little bit of reading around them, and some of them I've grouped together. I won't answer every one individually. I've also left some of the dietary stuff out a little bit because I think it's probably something that is almost a topic of its own, particularly brain-gut types of things. There's a lot of interesting research being done in that area, but it's still quite nebulous, and so I thought I'd leave that for another day. But let's make a start, and as I said, there will be a time for questions. So I wanted to start on this note. I've just come back from the World Ectrems Conference in Copenhagen, which, as some of you will know, is the biggest MS meeting in the world, of about 8,000 or 9,000 people interested in MS research, and it happens every year in a different part of Europe. And I think one of the really exciting things that came out of this, and actually answers some of the questions that people had about secondary progressive MS, was this trial here, the Hercules trial. Now, this was just an abstract, so it hasn't been published yet, but this is the first trial ever of all of the ones that have been done that have shown some positive attributes in terms of people with secondary progressive MS. So it delayed time to disability worsening at 6 months by 30%, and these are people who had had progressive disability over 12 months and no relapses in 2 years. So truly secondary progressive, patients with secondary progressive disease. So very exciting, and watch this space. There are a few issues with liver toxicity. Oh, sorry, do you want me to?
Yeah. Yes, if you could use the microphone, it would be helpful.
A few issues with liver toxicity that we get around by just doing lots more of tests and things like that. So, something there. And what it is basically is it's this BTK, so it's what's called Bruton's tyrosine kinase inhibitor, and it stops cell proliferation and survival within the B cell chain. So it sort of attacks cells that are similar to what we do with ocrelizumab, but in a slightly different way. So these were some of the questions that I got about sort of MS and things, and so I thought I would try and group them all together and answer them together. Does myelin repair over time? If you don't take disease-modifying drugs, what might happen? How do you minimize future lesions? And why don't all patients get disease-modifying medications? So one of the things I think is that we dichotomize multiple sclerosis into, we kind of go, this is primary progressive, this is relapsing MS, and this is secondary progressive. But of course it's much more complicated than that. And this slide I've just tried to illustrate that actually there is quite a lot of different sort of trajectories, if you like, of MS. And it can be very difficult on a one-off occasion to know exactly where somebody lies. And I know people sometimes express frustration at whether they're relapsing, whether they're secondary progressive and things like that. And it's not all that we're not very good neurologists, it's just that it's something that is often retrospectful. And we can't always know exactly where you fit at any one time. Now, the other thing to say is that nothing is black and white, so nothing comes on, you don't suddenly change from one to another. And one of the things that I think we are increasingly aware of, particularly with the new disease-modifying medications that really do shut down relapses, is that everybody, even from the beginning, will develop a degree of disability that creeps into the background. And this is what everybody is talking about, this sort of PIRA. And in fact, PIRA may be the sort of thing that this new drug, these new medications, which have actually been used in cancers for some time with Hodgkin's and some of the lymphomas and things, may address. So I think it's important to know that it's not black and white, and that there are a lot of sort of ins and outs around this. And so I know that everybody's very frightened. Everybody says to me, am I secondary progressive? Well, actually, as I said, even 10 years ago, there was probably some disability accumulating, but we just weren't sophisticated enough to pick it up yet with our tests. So what happens to the myelin? Well, we've got myelin with its oligodendrocytes hanging on and repairing it in the natural state. And what happens here is that when you get demyelination, this strips back off the axons here, and this is the myelin wrapped around it. And what then happens is there is a degree of remyelination, but there is some things that never remyelinate. Now this is a balance, and I'll show you this slide, which I think explains why it can be so difficult to predict where somebody is and where they're going. And that is that you've got all of these things up here, which are vary in different people. You've got demyelination and axonal loss. And we have some ideas of the things that have a low chance of progression, low levels of inflammation, those with fewer spinal cord, and this one like good endogenous repair. Some people repair incredibly well and other people not so much, and we don't understand that yet. Some people have very preserved axons, they only get the demyelination and then they remyelinate really well. Early treatment seems to be associated with better chances in younger age. But then we've got these things on this side, which is high inflammatory loads, spinal and cortical lesions, which we actually still can't see on MRI. A person who, for no fault of their own, has poor repair or mitochondrial dysfunction as part of the issues, and gets extensive loss. Now we know that delayed treatment can contribute to that, but not in all, and being a little bit older. So you can see that when we're weighing things up and trying to decide what's best for people, it can be incredibly complicated. This slide is sort of answers the question a little bit. Now, everybody's different, but if you take all comers, what we have seen over the years is that earlier the diagnosis and treatment, if treatment is appropriate, is put in place, then it will change the natural course of the disease. Not for everybody, and not for every type of MS, but this is our goal really, and we've certainly made great inroads in terms of this. It's important to remember, people say, why isn't everybody on treatment? We are, of course, restricted by pharmac, that there are a set of rules which we have to follow about who we are able to put on treatment. Like any drugs that pharmac fund, which are expensive, and these drugs are expensive, they put limits around them, and that is often associated with who they feel will gain the most benefit from it. And I won't go through all of this, but basically you have to have MS, that kind of is obvious, and it does sound funny, but you know, MS can be difficult to diagnose sometimes it's really easy, but there is a number of times where people kind of live in a twilight zone. They've had one attack, MRI doesn't really show very much, and there's this sort of long twilight period which is really uncomfortable place for people to be, where do I have it, don't I, and that can take time. That you have to be able to walk 100 metres with a stick, and that also, you know, we are soft on our interpretation of these, I would have to say, because in fact you're meant to have a relatively severe EDSS shifting attack to get on treatment, and that it has to be associated with a number of things, including MRI changes. So I think in New Zealand we do pretty well in terms of, and it would be fair to say that nowadays, the vast majority of patients who we see with a new diagnosis will start on treatment if they wish. Some of you asked me about the eligibility for people with primary progressive. As you will know, that the government have now funded ocrelizumab for people with primary progressive MS, one of those ones on the trajectory I showed you. And this is the current criteria. Again, you have to have primary progressive MS. But interestingly, you also have to have some motor deficit as well to be able to be on treatment and be able to walk. You can, as long as you can do 100 metres with a stick or bilateral support, then you would be eligible, and that you haven't had a previous history of relapsing MS. So I thought, I'll just go back. So I thought I would stop there and let people just perhaps give a few minutes to ask other questions, and then I'll move on to some other areas of questions that people asked. So does anybody have any questions around those sorts of things, or anything that was on your list that I haven't covered there? Yes?
Thank you. Just a question about the pharmac funding, because there was a webinar a couple of weeks ago from the MS Society, and my understanding is that pharmac doesn't look at sort of the society costs and benefits.
No.
Is that likely to change?
Yeah.
You know, the benefit of keeping somebody in work.
Yeah. So they do have a health economics component to their when they look at things. So yes, they do. It's an international standard, but it doesn't cover everything. The one thing that they don't cover, which we find frustrating, is the operational costs of their decisions. And that has a big impact on our infusions and other things. But yes, they take a range of things into account. And in fact, I think that was probably one of the things that got the primary progressive over the line, because as you may know, in Australia it isn't funded. So, yeah. All right. We'll stop again for other questions. Some of you asked me about vitamin D, and if you'd asked me 3 weeks ago, I would have come out and been able to tell you the answer. And then somebody spoiled it for us.
Oh.
So the whole thing about vitamin D came out of, as you know, this latitudinal gradient. So sort of empirically it made sense that if you have a disease which is much more prevalent away from the sunlight and less common near the equator, that maybe it's related to vitamin D, and that seems very reasonable. And so then the next thing is, well, if I take vitamin D, will that help? Now, as you know, and some of you may have even been involved in this, I don't expect you to know anything about this, but I'll just show you. This was the New Zealand and Australia prevalence study. So we did this study, and some of you may have been involved in it, where we looked at patients with very early MS, and we gave them either 1,000 units, no vitamin D, apart from sunlight and things they did naturally, 1,000 units daily, 5,000 units daily, and 10,000 units daily. And we had 270 patients, and we compared them all. This is the sort of MRI features, and this is the clinical relapses features. And what that showed is that there was absolutely no difference between the 4 groups. And in fact, at the very higher doses, there was just a suggestion in those who smoked that they might have been slightly worse off, actually, which was slightly worrying, particularly for people following the Jelinek, sort of getting levels up to 200 and things like that. But then at this conference I've just been at, the French did a very similar study, and they did find some differences. They gave people 100,000 units every fortnight, and what they found is that it had an impact on the MRI lesion, both expanding lesions and number of lesions at 2 years. It's only in abstract form at the moment, we haven't seen the detail, but interestingly, although there was quite an impact on that, there was no difference in relapses which is a bit hard to understand. No effect on disability, cognition, quality of life, fatigue, anxiety, or depression. And so it's a little hard to know exactly what we're doing here, and I think it's just going to cause more need for research and discussion. They did make the point that their patients who benefited didn't have spinal cord lesions, so there might be something about the brain, and also that the group with the severe deficiency of vitamin D. Now, we had very few people in our study who were very deficient in vitamin D, so it's possible that people in France are a lot more vitamin D deficient than we are. So watch this space. It's like everything. The side effects seem to be relatively modest, but I don't think that there, in my own opinion, is any evidence for high doses of vitamin D. All right, now I thought people would be interested in this, and I've got a surprise for you. So yesterday in Christchurch, we started doing our first bone marrow transplant, and we've got 2 planned before Christmas. And the first one was done in Auckland about 9 months or so ago. So I thought I would talk about the ins and outs of it, because I think there's a lot of misunderstanding still, and there's so much we still don't know, and that we are still coming to terms with or understanding. What happens when you have a bone marrow transplant? And I put this slide up because I'm aware that there is some group in Auckland, and there is also a group in Christchurch, I think they're in Merivale, who are offering stem cell transplants with fat cells. It's $15,000, and it's very expensive, and it's a sham. So if you hear of anybody thinking of doing this, there are lots of other ways they could spend their money a lot, they'd be better off spending it. So let me just tell you what happens as we go through a transplant. So what we do first of all is that the patient comes to the hospital and they get cyclophosphamide, which is a kind of a chemotherapy, and this stuff called CSF. And what that does is that it makes your white cells all come out of the bone marrow and out of the spleen and places like that and go into the blood. And they then suck all those cells off, and they put them in a bag and they put them in the fridge. Then you go home. This is just, the apheresis is usually a day or so, but it's usually a daycare type arrangement. Sometimes they have to bring people back several times to get enough cells. Then you go home, recover from that, and then you come in and you get, now this is called BEAM. We don't use BEAM, and I'll explain that to you a little bit down the track. But basically what we do now is a conditioning program, and that is basically blasting all of your blood cells, red blood cells, platelets, white blood cells, the works, and basically makes you completely what we call aplastic, that you have no functioning red or white blood cells. So you have to be an inpatient, and we keep you in a room where we keep sterility and make sure that you don't get any infections, because you've got nothing to fight it with except our antibiotics. And then, after a short period of time, we then, the hematologists, I don't, put your own cells back in to re-engraft and re-engraft basically, restore your immune system back to you again. So that is the process. The risks associated with it are largely here with infections, but there are also post-transplant issues as well, and I'll talk a little bit about those. Now, is that right? Yeah, maybe. So, what's the idea of it? Well, we don't know which cells are the ones that are causing trouble in people yet. And so what we do is that we destroy the entire repertoire of cells. And this then ablates them all, and then when they're put back in again, your systems re-expand. You get new blood cells, you get new T cells, you get all of the white cells come back again over about 6 to 12 months. Some of those will be good cells again. You might have a few bad cells still, but the idea is that the rebooting of your immune system will give you a new and better immune system. Now, there's still a lot of research around what that looks like, but a lot of that happens in the thymus, and you get a repopulation of new T cells. And then hopefully you've got a new immune system that will behave a lot better than the one that you had before. Now, it is not a cure, and I think it's important to know this. So part of the problem with bone marrow transplant is that we don't have good data yet. There is very little randomized trial. The MISS trial, which people quote, was a bit of a difficult trial to really evaluate, because the patients who didn't get a transplant did terribly, which would not be what we would expect. But there is a trial coming out of England at the moment called the Starry Nest trial that has just finished recruitment, and in that trial what they've done is that they have taken a group of patients and they are randomizing them to bone marrow transplant or to ocrelizumab, which is probably one of our most powerful infusion treatments. But if you look at all of the old trials, so these are references, so there was 41 in this trial, 145 in this, 24. So these are just trials that are clumped together. Now, none of the patients match particularly, some of the protocols are different, so it's very difficult to really make decisions about them. But what you can see is, some of you will be familiar with this term NEDA, which is no evidence of any clinical disease and no evidence of any disability that's new and no evidence of any MRI activity. It's a bit of a golden goose egg, because very few people will actually be able to achieve that, even with our good drugs. But it is one way of looking at seeing that you can see that overall, even with transplant, people do develop new lesions and new relapses. And in some trials, they haven't done well at all. Now, we can't make anything about this, but you can see that there's a lot of diversity around these trials and why it's been very difficult to interpret exactly what's going on. This is a similar type of thing, because a lot of people say to me, well, what about people with secondary progressive MS and primary progressive MS? Why are you not transplanting those patients? Well, if you take people with relapsing MS and you look at the EDSS score, and I think most of you are probably familiar with the EDSS score, so low disability down here. By 4, you've got disability in a number of different areas, and by 5, 6, and 7, you're starting to have difficulties with mobility and things like that. By the time people reach 8, they need to use a wheelchair. And so what you can see is that patients going into these trials, they were often having a really bad time just before they got transplanted. So you can see that this patient's gone from a 2 to a 6, over a very short period of time. So this is very aggressive MS that you're seeing. And there is no doubt that if you look at it, then this black line is the overall group. And you can see that it does work, it does stabilize the disease, and people do get benefit. Some people, often ones that have been doing really badly, even come right back to here. But despite what you read on the internet and all of those websites that I had a look through last night and thought that this was going to be the best thing since sliced bread, is that yes, there are patients who do extremely well. There is no doubt about that, and who stabilise for long periods of time, and we certainly see people like this. Overall, people stabilise, but there are still a significant number who continue to progress. And we aren't very good yet at picking who is who, and that is part of the problem. What about for people with progressive MS? Well, again, a lot more, less sort of dramatic changes before, but you can see that apart from the occasional person who does very well, the majority of people may get some stabilisation and may continue. And the problem from our point of view is this doesn't look much different to some of the drugs that we use. And in fact, some of the drugs we use, we would expect better than that. So, you know, these are the kinds of challenges that we're dealing with. Nothing's black and white in MS. The other thing too is it's not entirely safe. So this is transplant-related mortality, and what you can see is that we're getting better at it. So pre-2005, the mortality was about 4 to 5%. This is in everybody that was transplanted. Since then, transplant techniques have got a whole lot better, and you can see here that it's now about 1%, which is what our unit and the Auckland unit quote. If your EDSS is higher, your risks are higher. You can see here compared to those who are under 5.5. If you have relapsing remitting disease, your risks are much lower than somebody who has secondary progressive or progressive disease or more advanced disease. And actually, 36 is their cutoff. And you can see that as we get older, 36 worrying me a bit, you can see that the risks go up with age as well. Also, which technique we use. So the low efficacy treatments aren't very risky, but they're probably not all that helpful. The very high ones carry significant risks still. We are using the intermediate transplant protocols at the moment. So I know that a lot of people feel that we've been behind the 8 ball in New Zealand and that we haven't been doing these. We are doing them. We have a committee now of 6 neurologists across the Motu, all of whom are MS experts, and we accept referrals from neurologists asking if this person would be appropriate for treatment. And there are situations where a patient can't take a certain drug, for example, that we also give consideration to. And in fact, when I look at the international guidelines, I think that we're reasonably flexible. This is the American Academy guidelines. So they only recommend it in people with relapsing remitting disease who have clear ongoing clinical and MRI activity. We go up to 55, they only are at 45. No longer than 10-year duration, we're at 50, we'll accept people up to 15 years. Below 6.5, so you have to be able to walk independently with one stick. And that you have had to have failed at least 2 disease-modifying drugs. No other significant comorbidities. Diabetes, heart disease often make transplant very dangerous, and just a few other issues. This is I won't go through this, but this is the Australian guidelines, also very similar, and actually even they go up to 7 in terms of disability, but they too are 10 years and they won't transplant over 50. So, yeah, so, oh, now I've really done it. That's not what's meant to happen. Yeah, all right. So, does anybody have any questions? I know that there were a few questions about transplant. Some people are asking about how it works. Does anybody have any questions about that?
sounds expensive.
So in the public system, free. Those people that go offshore, it is expensive.
Yeah, but I mean, the time you'd have to take off work. If
Yeah.
I basically work full time, so,
Yeah.
and I don't want to do it anymore.
Yeah, no, that's right.
But yeah,
It does have some expense, although, coming in for natalizumab every 6 weeks is also a fact for a lot of people who work, and we appreciate that. Sometimes people, in terms of their lifestyle, they're going to live overseas or somewhere like that where they don't have access like we do. So there are sort of reasons around that. We tend to just take into account is this person the right person from their MS point of view? Yeah.
I mean, how long would you have to take off work?
It
When you've got
depends.
no immune system, so.
Yeah, well, you're in hospital usually so the immune system usually comes back over 14 days. So usually the whole process, once you get the cells taken off, you can go back to work for a short period of time, and then you come up for the transplant. We usually have people in Christchurch for about 2 or 3 weeks if everything goes well. Then they go back to recoup, and so you're probably off work about 6 weeks, I would say. Yeah. Yeah.
Is EDSS still the best method of testing disease progression? Is maybe something like functional composite might be a better testing regime?
Yeah, and in trials, of course, functional composite is what we do. But in the clinic, and you know what our clinics are like, these tests take a long time to do, especially on the 3rd time that the patient's dropped all the pegs on the floor. And the other thing too is that sometimes that'll give us information that doesn't actually change what we're doing. So in trials, it's really helpful, and it's a good point. PIRA, nobody yet has a good way of assessing PIRA. All right, I'll move on to the next thing. Some of you asked me about scans. Jessica has a question. Many of you will know Jessica. Jessica Deacon is our senior MS nurse at Christchurch Hospital extraordinaire, and she offered to come along today, and she's going to do some of the input about complementary and brain health and things.
There was just a question from somebody around if there's any research about stem cell looking into repairing myelin.
Yeah, very good. So it's still a bit unclear. So with that new sort of lot of cells that you have, the question is where those people suddenly improve quite a lot. Is it because they're no longer having any further inflammation and we've dampened that down and that allows the natural myelin to heal, and it does? Or whether there is something about the new cells that help with repair? I think it's probably a combination of both, and certainly a patient that I can think of who had a transplant who's done very well had a moderate degree of disability when she had her transplant, and over about 3 or 4 years got better and better, and her examination got better and better, and she has remained stable. So I think that there is repair, and why that is and how that is, I don't know, but yes, it definitely. But we also see that in patients with natalizumab over about 2 years. If they're treated effectively, then they get some improvement. And cells will myelinate if they can. Yes?
With the age group and the people that are put forward for this, is it a majority of people are at that age, or is just you don't have enough in the older age group that satisfy all conditions?
Yeah, potentially both. The transplant doctors get a bit edgy once you're over 55, and that's because they're used to doing bone marrow transplants day in, day out. And we know, for example, with patients with chronic myeloid leukemia or some of the myeloma patients that they transplant, they do transplant them into their early 60s, but the complication rate in that age group, even if they're healthy, is higher. But we've had this discussion, and Jess will laugh because I said this the other day to the hematologists are terrified of patients with MS. So these two patients that we're doing, they ring me and I said to them, these will be the easiest patients you ever transplant because they're so well otherwise. So hopefully I'm right. All right, so scanning. There's a lot of questions about why we scan and when we scan. Essentially, there are three reasons to scan somebody. A diagnostic scan for either the disease, yes you have MS, no you don't have MS, or yes you've had a new relapse with new disease activity. A monitoring scan, and I'll talk a little bit about that, and a safety scan. So let's talk about safety scans first. As many of you will know, that when we first had natalizumab, we were trucking along really well until in 2004 we had the first case of PML. And that, of course, meant that we nearly lost the drug off the market because it was a devastating condition. The initial patients died of this condition. It was unexpected, and Biogen then had to put a really extensive risk program in to reduce the risk of this happening ever again. And so out of that came the need to scan. And so what happened was that anybody on natalizumab, we had two things. We have JCV testing now for you, which we do every 6 months, and we had yearly scans, largely not looking for disease, but for looking at whether there's any hint of PML. Now, that was in 2004, and time has moved on. And what this shows us is that now that we've moved to 6 weekly infusions, then these blue lines are people who have 15 or so infusions a year, so largely the 4-week group, right the way through. If you have 10 or less scans over the year, it drops away. And in fact, in the group now who have always been on 6 weekly regimens, in this study, there were no cases. So you'll remember this little risk dial that we had here. This probably is no longer terribly pertinent. It doesn't mean that the risk is gone completely, and we still need to be very vigilant, but the risk has significantly decreased. And for that reason, when people are getting natalizumab 6 weekly, the need to do those safety studies are a lot less. We spend about, I worked out it was about 5 million a year across New Zealand, scanning patients for safety and monitoring in an environment where MRI scans are really hard to get. And so we've changed some of our scanning procedures recently, and some of you may have noticed that. The other thing too is that with the modern drugs we're using, here is placebo patients. This is on ocrelizumab, I think. And here is the blue lines are MRI activity in people who are on ocrelizumab. And what you can see is that after the first year, 0.0, it's virtually nil. And that's our experience too. How many times do I write to you all and go, I've just reviewed your MRI scan and I'm pleased to let you know that it is completely stable with no new lesions and no new expanding lesions. And that would be, I would write that 90% of the time. So again, on some of these drugs, once people are established and stable, then we probably need to do a lot less in terms of MRI. People ask me about why don't I get my spinal cord scanned, and this is from the world group at in Milan, who are the sort of the best in the world with MRI, and basically they've said that in light of the fact that we use different machines, different protocols, spinal scanning is really not recommended because it isn't useful for monitoring. This is from this medical centre here that have some of the best radiologists in the world in Sweden, and they did a thing where they looked at patient scans, and even in best of hands, they only picked up 77% of new lesions. So, and in our situation where we scan at Burwood Hospital, 1.5 Ts, 3 Ts, very difficult to compare scans. So, the other thing too is that, and I know people say, oh, can I have another MRI scan because I want to see how I'm doing. The correlation between what your MRI shows and how you're doing is not very good. And you can see, these are the typical lesions you see. You can see that this patient's got very low, pretty low EDSS. They've had MS for 23 years, not much disease burden. You think, oh, that's good, you see, treatment's working. This person, 11 years, slightly higher EDSS, but this person, 7 years, much higher EDSS and virtually no lesions. And this again is the issue. What you will notice is that this person's ventricles have got a bit bigger. So remember I talked about mitochondrial and endogenous and different aspects between patients. This patient has a much more neurodegenerative aspect to their MS than perhaps other people do. So this is something that I've proposed across the country, and just basically that if you're stable, that you don't need regular scans after the first 2 years of treatment, that we still will do them when they are required clinically, and every now and then we'll do a few just to kind of re-baseline people, but we're going to be doing less MRI scans. All right. Now there were a couple of other questions I thought I might answer, and then I was going to get Jess to come up, and there are some more questions that we might go through as a team. One of the questions was, and maybe Jess is the best person to answer this, is just how our system works and how people access it. I think the question was, how do you see Deb, the MS nurse, the neurologist, the neurophysios? So I guess from my point of view, we can't replace your GP. So we have over 500 patients on treatment at the moment, and so we can't do everything. But what tends to happen is that we encourage you to see your GP. If the question is about relapses, or it's a question that you want to ask of the nurses, you can ring in, and Jess has the numbers, and you can leave a message. We'll try and get back to you after 72 hours, except over long weekends and things. If it appears that this is something that we need to address, we will put you into the acute clinic where you will be seen. We do 3 acute clinics a week, and you'll be seen by a neurologist. Sometimes the nurses will deal with it, and we will communicate, and if you've got a question for me, Jess will come and find me and ask me. So we do referrals to community-based physiotherapists, neurologists. We do those referrals. Unfortunately, we don't have any control about what their wait lists are like. We can make the referrals, and we can hope that people get in. And generally they do, but it can take some time, I think. I can talk about MSBase at the end. Yes, we are on MSBase. MSBase is a global database whereby I use it in the clinic, and many of you will have seen me and had a look at your trajectory and all the medications you've been on, which is great in the clinic. And then we can, with your consent, upload your de-identified data, so nothing personal about you, just your age, your sex, what kind of medications you've been on, what your scores are, to the international database. And that database then uses information from Australia, Canada, US, all over the world to ask the questions that we want to know from large data sets. So we are currently encouraging, and we're hoping to get everybody on our MS-based program. All right. Some people said that their neurologist said that after they're 65, they won't get on any treatment. What we do know is that MS does tend to burn out, and because of the kinds of medications we're using, the risks associated with them get higher as you get older and you've been on them a longer time. And the whole world at the moment is looking at exit strategies and how we de-escalate people off certain treatments but keep them well. And there's still not a lot of certainty around that at the moment, but we are now involved with that. So I will let Jess take over.
Alright, so I'm just going to cover some of the symptomatic questions, and just feel free to be super interactive, so if you've got any other questions, just ask me as it comes up. So one of them was around fatigue. So why does my MS cause me to be so fatigued? Can you hear me fine? Is that okay? Is that loud enough? Yeah. And what can I do to so that this impacts me less? So MS fatigue is very challenging to manage, as I'm sure you all know. One of the things I talk about in clinic is what causes MS fatigue, and there's sort of two main parts to it. So there's primary fatigue that we talk about, and that's about the energy that it actually takes for that action potential to move down nerves that have had some demyelination. And that is incredibly fatiguing, and that is why you do feel a lot more fatigued than someone without MS. So I tend to say to people that it almost takes twice as much energy for you to do anything than what it does to someone who does not have MS. And that sort of just sums up how real this fatigue can be. And then there's something that we call secondary fatigue, which is everything else. So every single symptom that MS can cause can be fatiguing on that person. So for example, if you're someone who lives with pain is exceptionally fatiguing, and that takes a really big toll on people. If you're someone who has bladder or bowel issues, if that's then interrupting your sleep, that's going to contribute to your fatigue. If you're on a raft of medications that are helpful to manage the symptoms of MS, but often a lot of the medications that we use contribute to fatigue, or one of the side effects of that is possibly fatigue. So as you can see, we've got to really combat fatigue by looking at it in lots of different ways. And what we try to encourage people to do is I usually start off with a fatigue booklet, which covers everything I'm talking about now in more depth. And then we really encourage people to connect with the health navigators here at Braintree, to spend some time looking through all the aspects of their life and what could be contributing to their fatigue. So making sure that you're having a medication review with your GP, seeing if there are any medications that either might not be necessary or you can reduce the dose on. Thinking about health and well-being, so thinking about the impact exercise can have on fatigue levels, and going about that in a safe way, because I appreciate that if you're exceptionally fatigued, then thinking about trying to exercise is going to be really, really hard. So coming to see Eamon here, who can help you start making positive choices and also create a program for you that is actually achievable. I never say start off with, start with 5 minutes, I would say, and then try and do that 3 times a week or something small like that. And then you feel really good and empowered by achieving those goals, and then you can build on that. Thinking about diet and lifestyle factors, so looking at your diet and ways that you could possibly improve that. We don't tend to endorse one particular diet through our clinic. We tend to say that like eating a Mediterranean diet or that sort of way of life tends to have the most evidence, or the best sort of for us, and that's for everybody, not just people living with MS, but looking at ways that you can get enough protein into your diet. Make sure you've got lots of vegetables and fruit, lots of good grains and that kind of thing, and obviously all the stuff that we love, reduce. And then thinking about the impact of weight and how that can also impact your fatigue. So if you are carrying more weight, that is then going to be more fatiguing on you as well. So that ties back into a healthy diet and also getting exercise as well. Any questions around that?
Thanks, Jess. Just what the definition of fatigue is, because there's sort of fatigue as in fall asleep watching the TV after doing what a lot of us do. And then there's the heavy legs, you just can't get things to work, which is like brain to legs fatigue. Are there different definitions, or is?
I think it's, I don't have the perfect definition, but some of the things that patients say to me is, can't think because of the brain fog. My body's moving through treacle or through sand. I try to rest, but when I wake up, I don't feel any better. So that's that overwhelming mind and body fatigue that isn't resolved by taking a nap. Yeah.
So that's what you're covering really, is the bits that sleep doesn't fix.
Yeah, as you said, the other fatigue, of course, is when you demyelinated, when you strip those axons, some of them die off, and then the ones that are still present have myelin that's kind of a bit like if you burn yourself, it's not quite as robust. And so as you put more and more electricity down there, i.e. walking and trying to walk, then you get what we call conduction block, and basically those areas just fail. And that's what happens sometimes when people say their legs give way, or they get into a hot tub and then find they can't get out again. And sometimes fampridine, the medication that we use, in about 15% of people will be helpful for that. It seems in some way to improve that electrical circuitry.
And just on that note, there is also a couple of medications that we can use for MS-related fatigue as well. But we try to take a holistic approach first. Medications can only take us so far, and actually the medications we do have available only work in a small percentage of people. So it's about looking at all these lifestyle factors first, or in conjunction with, if we are going to consider medication. And
Can
then,
I just, sorry, that fampridine says not approved for MS. Yeah. For fatigue, fampridine not approved for MS. Is there one that is approved?
Not a pharmac approved as opposed to.
Costs you.
yeah, so that's just saying that it's not funded.
Yeah, is there a funded equivalent?
No, there is a slightly cheaper version of fampridine that once someone's established on it, we do sometimes recommend that, which is a little bit less.
Yeah.
And it's available through an Auckland pharmacy. Yes, yeah.
What's that called?
Amino-4-pyridine. Yeah, and then in terms of the fatigue medications, amantadine is something that we sometimes start off with, that is funded. And then there's a medication called modafinil, which is not funded. Costs about $5 a day. So I tend to say if you're someone who drinks a coffee a day to get through your fatigue, then replace that with that. But that is not suitable for everybody either. We need to look at the list of medications people are on, make sure there's no interactions. And then one of the components up there that it talks about is the mental health impact. So as you know, living with a chronic disease comes with a huge mental health impact, and conditions like anxiety and depression, which unfortunately is more common in patients living with MS than the general population, does impact on fatigue levels as well. So another component of looking into this is the psychological health. So looking at getting counselling or having good family support, and really supporting yourself through that aspect of health as well.
So we just need a magic bullet for something who works full time. It's really fatigued. But yeah, I mean, I go out, I walk a lot. I I do, you know, quite a lot of physical exercise, yoga, go swimming. If you could find a happy, nice way to relax, to get your breath back so that you can work another day. I only work half a day on Friday now, because by Friday, I'm shot. So I take the weekend to recover for Monday. So, yeah, if I can have a magic bullet, that would be really good.
And I think about for everybody, it's finding their balance.
Yeah.
And everyone knows when they've done too much or taken that too far. And I think definitely people in the early stages of diagnosis sort of push this into the background and try and continue doing everything. And then they start to learn that actually that doesn't work, and that it's about finding new ways of, I guess, managing things and actually pacing yourself, which is probably the word I use all the time in clinic. But I appreciate that that's really challenging, because we're used to a fast-paced world where we want to do everything and we want it done yesterday. So
It's not always us, it's everybody else.
Now there was a question around, I hear people get benefit from ice plunge baths, hyperbaric treatment and constant exercise. What do you think about these complementary treatments? So first off, one of the things that we talk about quite early on in clinic is the MS Brain Health Initiative. So this is focusing on ways to help improve your brain health to minimise the impact MS can have. So we all have this amazing thing called a neurological reserve, and unfortunately as we age, it does deplete a little bit. But if we cause any direct damage to the brain through MS relapses and lesions, that can speed up that process. So what we want to achieve through the MS Brain Health Initiative is to help make our brains as healthy as possible so we can minimise the impact MS can have. So they have done research into exercising, not drinking too much, not smoking, and maintaining a healthy weight, and how these actually significantly improve the outcome for MS. So we think it is really important that you have both components, that you take these lifestyle factors into account, as well as looking at treatment options, and together they really complement each other, and patients can get the best outcomes. So in terms of ice plunge baths and hyperbaric treatment, I'm certainly not an expert on either of those. As practitioners, when we're recommending something to someone, it has to have scientific evidence for us to be able to recommend it. In saying that, when we get anecdotal evidence of patients having a good experience from something, I'm certainly not the person to tell them that that's not a true lived experience for them. If they are having a positive benefit and it's helping their symptoms or their mental health or how they cope with a chronic condition, then fantastic, and carry on. But yes, there's no sort of, I won't sort of advocate for hyperbaric treatment, but there is evidence around how much ice plunges can improve your dopamine level, so they make you feel really, really good. So as long as you're doing it in a safe way, then I think that's absolutely fine to do. Any other questions about health and wellbeing, or any other sort of things you'd heard of that you wanted to try?
Any other general questions from everybody? Thank you very much for inviting us, and hopefully we've been able to give you a few things that you each learn something that you can take home that you might not have heard before. I know so many of you are so well informed. It's hard to find things here which you won't already know about.
Oh, well, it was an afternoon of surprises for me, so thank you so much. The first surprise actually was Jess coming. So thank you for joining us. It was lovely to have you for the last quarter of the session, and I think it was fabulous to share the Ask Me About session amongst such wonderful people who match, by the way. Did you do that on purpose?
I haven't actually seen Debbie all day. That's a surprise as well.
We didn't text each other this morning.
The other wonderful surprise was about the first bone marrow transplant happening yesterday in Christchurch yesterday. That's, you know, you heard it here first. Well, most of you heard it here first, I think, probably. And probably the third afternoon of surprise for me, the third thing was that vitamin D remains an enigma. Who'd think? I know. So fantastic, and thank you very much for both of you answering the questions that have been put forward by this very lovely audience. Please join me in thanking both of them.